So in COPD, how it is different from asthma is you have symptoms that is persistent.
अच्छा
There can be flare-ups, but
अच्छा
persistently you are symptomatic.
अच्छा
So people confuse a lot this with asthma and COPD. People think if you have only breathlessness, that is when actually it is asthma or COPD.
अच्छा
No, even just a chronic cough
अच्छा
can be asthma or COPD.
अच्छा
So as in when the disease worsen, that is when you start developing breathlessness.
the breathlessness associated with aging and the breathlessness or any of these symptoms which are associated with COPD, how do people differentiate between these two?
If you are finding it difficult to carry out your normal routine activity, which you were able to carry it out prior to this, it means you are having breathlessness and disease process is worsening.
We rarely pause to think how effortlessly we breathe until that ease slowly starts slipping away. COPD often begins as quite inconvenience, then quietly rewrites a person's everyday life. In today's episode, we break down COPD in a way that finally makes sense to all of us. What triggers it, what we often miss, and what can be done long before it becomes disabling. From smart inhaler use to lifestyle shifts that truly matters, this discussion is about understanding your lungs and reclaiming your breath. Joining us, Dr. Harsha Jain, who stands as an exceptional pulmonary critical care and sleep medicine specialist, distinguished equally by brilliance and dedication. Ranked first across India in the NET SS examination, her academic trajectory has consistently set the highest benchmarks. A gold medalist, a college topper through her MBBS, MD, and DM training at prestigious institutions, she embodies clinical excellence shaped by rigorous practice and advanced intervention pulmonology expertise. Her skill set spans cutting edge procedures from complex airway interventions to comprehensive sleep disorder managements, reflecting both depth and precision. With impactful research contributions and unwavering commitment to patient centered care, Dr. Jain presents a rare combination of mastery, compassion, and progressive leadership in respiratory medicine. Welcoming Dr. Harsha Jain. Hello and welcome to another episode of Sahyadri Health Talks. I'm Dr. Tushita and today we have with us Dr. Harsha Jain. Hello ma'am, how are you?
I'm good. How are
Welcome.
you?
I'm good. I'm doing absolutely fine. Welcome on Sahyadri Health Talks.
Thank you so much.
And a gold medalist, a college topper, and a thriving practice with a smile that I have never seen fading. How do you have it all?
It's all passion for the subject which I have, so which makes me happy all the time.
So this pulmonology was your first love always.
Not exactly, but eventually I started developing love for the subject.
Okay, so we are going to discuss about COPD because the month of November is a COPD month. So while there's a lot being spoken on asthma and other respiratory conditions, so if you have to explain COPD to a layman, what would you how would you describe it?
So now imagine we have lungs. So lungs have a air sacs. So then we have a breathing pipe. So to the common people, I can say there are some tubings and then you have a air sacs. So now what is happening in COPD is there is an inflammation in the airway. So whatever the breathing pipe is there, so you have inflammation in that.
Acha.
And the sacs which we have, that is losing its stretch. So imagine lung like a balloon. So you're breathing in, balloon inflates, then you exhale, the balloon deflates.
Okay.
So what is happening in this patient is as there is an airway narrowing and the stretching is lost. So for them, breathing becomes difficult. So imagine now you have a candle in front of you and you have to breathe through a hollow pipe.
Acha.
And imagine one more candle wherein you will have to breathe through a straw, which is
Acha.
difficult.
Yeah.
So breathing through a straw is difficult compared to the hollow pipe.
Yes.
So exactly same thing happens in COPD patient. As the airway is narrowed, they feel it difficult to breathe out. And as they are not able to breathe out completely, so air is getting trapped.
Acha.
So this creates breathlessness in them.
Okay.
So it's a simple thing. We can say that COPD is basically you have difficulty in breathing.
Okay, so why it happens at the first place? What are the causes?
There are multiple causes. So many people are just aware that if you smoke, you're known to have some lung disease.
Hmm.
One among them is COPD.
COPD.
So there are many reasons wherein COPD can happen.
Hmm.
So coming to our Indian part,
Mm-hmm.
even in rural areas, you can see many people are using chulas.
Hanji.
Okay, we use wood fire, we
Yes.
use cow dung.
Yes.
So these all create a indoor pollution.
Acha.
So eventually you develop COPD even because of this.
Acha.
And next is most common is secondhand smoking.
Mm-hmm.
So husband
Somebody
will be
is
smoking,
smoker.
somebody else in the family smokes.
Hmm.
Eventually you are exposed. So rural women usually
Mm-hmm.
are exposed to all this.
Mm-hmm.
So these people can develop COPD.
Hmm.
And coming to India per se, we have a lot of cases of tuberculosis.
Mm-hmm.
So once they recover from tuberculosis, they can have obstructive pulmonary disease, which we call it as TOPD. So
Acha.
tuberculosis related airway disease.
Obstructive disease.
So even for COPD, one of the causes is your
Tuber-
tuberculosis.
Okay.
And supposingly you have asthma since long, but you have never taken treatment for it. So
Acha.
untreated bronchial asthma
Long
standing
untreated
untreated asthma, it is also a cause. And supposingly children have repeated recurrent childhood infections.
Acha.
So these can eventually in
So
the
when you say
later,
childhood infections, what kind
Yeah.
of infections are you talking
so it can be, see, what happens is there are many diseases in the children.
about?
So one is, suppose you are prematurely born,
Hmm.
or these all things make you prone for multiple infections. And in children especially, you are prone for multiple
Yeah.
infection if your immunity and all is not good.
Yes.
So non-treated repeated infection
Hmm.
eventually lead to adulthood respiratory disorders.
Disorders.
So one among them is bronchial asthma and one among them is COPD.
Okay.
The main problem what happens here is people are only aware of asthma.
Acha.
So what they say is mala dam ahe.
Mm-hmm.
So they do not understand that asthma dam is different
And this
and
is
COPD
different.
is different. So how can you differentiate it?
Hmm.
In asthma you have breathlessness or cough, but it is
Acha.
intermittent.
Acha.
So suppose a climate trigger is there, a pollution trigger is there,
Hmm.
an allergen trigger is there.
Hmm.
So you have symptoms.
You have some reason why it is
Yeah.
coming up.
No, in this also you have symptoms,
Okay.
but you are triggered by something and you have symptoms.
Acha.
In between the symptoms, you are symptom free totally. Suppose
Acha.
you have one episode today,
Mm-hmm.
for few months you are fine, and again you have some trigger and you have symptom.
This we are talking about
Bronchial asthma.
bronchial asthma.
So this is what happens in asthma.
Hanji.
So in COPD, how it is different from asthma is you have symptoms that is persistent.
Acha.
There can be flare-ups, but
Acha.
persistently you are symptomatic.
Acha.
So people confuse a lot this with asthma and COPD. And one more thing, what is important is people think if you have only breathlessness, that is when actually it is asthma or COPD.
Acha.
No, even just a chronic cough
Acha.
can be asthma or COPD.
Acha.
So as in when the disease worsen, that is when you start developing breathlessness.
Okay, so what is normally considered ki, if you are breathless, you're having breathlessness, that means
It is asthma.
yeah, it's asthma.
So you feel that till the time I don't develop breathlessness, it means there is no respiratory problem.
Correct.
No, it is not like that. Even before you develop breathlessness, you can have chronic cough.
Okay.
So these all symptoms you should not ignore.
Okay.
So whenever you have any cough that is lasting for more than 2 weeks,
okay,
you should always consult an expert.
So can we say that cough would be an early symptom?
Yeah.
Or do we have anything before that also?
No, actually cough, see, there are traits. See, few patients develop breathlessness early. Few patients develop cough early.
Achha.
And sometimes actually more than 90% of the patient have both the symptoms by the time they come to us.
Achha.
Because most of the time they just attribute all the symptoms to seasonal variation,
aging,
travel, aging. So these all things are common problems or common myths patient have. Till the time I don't, मला दम जेव्हापर्यंत येत नाही तेव्हापर्यंत मला काही त्रास नाही. This is what their perception is.
So ma'am, do we see any particular age group reporting higher incidences of COPD?
No, actually, if you go by literature, there are many factors which are responsible for COPD. But actually what we see is COPD coming to us in a OPD, it is usually elderly. I commonly see after 50 or 60.
Okay.
So I usually come across, because early if you have these symptoms, you usually come.
Achha.
Because see, if you compare to an adult patient and an elderly, adult patient move a lot. They climb stairs, they run a
Yeah.
lot, so
Yeah.
they develop symptoms early, so they come to
Acha.
you. But
Acha.
it becomes very difficult in elderly,
Yeah.
because they are, most of the time they are confined to their home,
Home and restricted
restricted
movements. Yeah.
movements, so usually they don't have so many symptoms.
Yeah.
So I think it's different in both the individuals
So
and
in
both the
such
group.
cases, when, as you are saying that, it's mostly elderly patients who come. So how do you explain this to our audience that the breathlessness associated with aging and the breathlessness or any of these symptoms which are associated with COPD, how do people differentiate
See,
between these two?
if you are finding it difficult to carry out your normal routine activity which you were able to carry it out prior to this,
Mm-hmm.
it means you are having breathlessness, and
Mm-hmm.
disease process is worsening.
Mm.
Suppose, just imagine,
Mm.
just going, bathing yourself,
Mm.
dressing yourself, undressing yourself. If these all symptoms have started now,
Mm.
it means your day-to-day activities are getting hampered.
Hampered.
So when it comes to a breathlessness because of aging, you feel breathless due to the age after walking for certain distance,
Mm.
and after that you're totally symptom free. In this, it is not like that. Even with the slightest movement, you
Acha.
have breathlessness.
Like things which you were able to do normally
Yes,
before.
normally before. Now all of a sudden you find that, but actually what happens in this is they feel, supposingly, I'm totally okay, and after some days I find that I'm feeling a little breathless. Usually they attribute everything to, maybe I'm smoking, because of that I'm having
Ah.
cough. Maybe it is like, I traveled, because of that
Mm-hmm.
maybe I'm having all these symptoms.
Mm-hmm.
But actually, patient who was totally fine and gradually he's developing symptoms, and he says that he's finding difficult to do even day to day activities. And
Mm-hmm.
then especially we should take a special consideration for these symptoms.
So, do we have any tests or diagnostic things to rule out these early? Because these days, annual health checks are quite, people are aware about annual health checks and they usually get it done. So, are there any tests that can be done, annually once or something like that to
Yeah.
rule out these?
So, see, as I told you, there are multiple reasons wherein you can develop a COPD. Supposingly, you had tuberculosis in the past.
Acha.
So, what we advise patient usually is,
Mm-hmm.
you should get a spirometry test. It is a lung function test basically.
Mm.
It detects your lung function,
Mm.
and if there is any abnormalities in the airways or inflammation,
Mm.
it finds it out. So,
Mm-hmm.
it is basically a test which we carry out, which we call it as spirometry. So now what we do is, in smokers after 40, usually you should better get a spirometry done every year. First thing is, you should stop. You should not
You should stop smoking.
Yeah. And next is, supposingly you had tuberculosis in the past. We usually advise them, you get an annual spirometry done.
Acha.
And any people, sometime occupational exposure, fumes and all that,
Yeah.
that also, those factors also lead to COPD. So
Acha.
these patients, in the company can form a norm that, every year you should
Get
these tests,
thing.
PFT. As in health checkup, you include ECG, blood test, and everything.
Okay.
You can, in the risk group people, you can just include spirometry.
Spirometry.
So,
So spirometry would be one of the tests that can
Yes.
be included. PFT, you said one.
See, one of PFTs, it is a general term for pulmonary function test.
Function
one
test.
among them, one
Is-
test among the pulmonary function test is spirometry.
Okay. And anything
Yes.
else that needs
So
to
what
be
we
added?
can do is X-rays.
Acha.
So what happens is, sometimes what we see is, accidentally patient would have got X-ray for something else,
Ha.
and there are few signs in the X-ray which will tell us probably the patient is going for early COPD, though he does not
Acha.
have a symptoms. There are few X-ray changes based on which we see that there is early COPD. And if you find that X-ray changes are there and some risk factors are there, then we suggest those patients go for spirometry, though you don't have symptoms.
Acha.
So we follow them up every year.
So it brings an inquisitiveness in me to ask you this question, that when COVID happened, right, a lot of X-rays, chest X-rays and CTs were done. So did we see an increase incidence of COPD?
It did. I mean, see, you treat patient when symptoms start basically.
Yeah.
But then we found that there were CT was done for COVID per se. But then we found that the changes of COPD are already existing. So such patient, I think, we can pick them up and find out. We call it as pre-COPD or early COPD, before even the symptoms develop.
So let's talk about inhalers. Okay, what role does an inhaler play here when it comes to COPD?
See, normally what we do is, there's a pathology in the lung basically. So you have a disease in the lung. So now we have inhalers. So they come in a capsule form or an inhaler spray form.
Yeah.
So what we do is, we inhale it, so that lung directly goes into the lung.
So direct
Yes, it
exposure,
goes into the
yeah.
lung. So you breathe in through the mouth, through the inhaler, and it goes to the lung.
Hmm.
So basically, what it is gonna do is, as you know, as I explained in the previously also, there's an inflammation in the airway.
Yeah.
So basically, these help in reduction of the inflammation,
Mm-hmm.
and also they help in the dilatation of the airway, because your airways are narrowed now because of the inflammation. One is reduce the inflammation and also dilate the airway. So now what you were breathing through a narrow straw, now it is little bit opened up. Not completely, but definitely
better than
significant.
before.
So with this, it makes your breathing easier. And next is, these patients are repeatedly prone for infections and repeated flare-ups.
Acha.
These are the medication which helps in reduction of flare-ups also. So when your flare-ups are reduced, your quality of life, your
Rest everything
psychosocial,
falls in place almost.
yeah. So what we see in this patient, the common problem what patient come to us is, we are not able to attend the social gathering because of our constant cough and
coughing,
whatever the sputum is coming out. Still there's a social stigma with the coughing and the everything. So the patient mainly comes to us saying, we are not able to move anywhere because of this. So in these all cases, the treatment of choice remains in COPD is inhalers.
So what's the most common mistake you've seen people doing while using inhalers?
I can say more than 90% of the patient do not know how to use inhalers.
Okay.
So what happens is, in our OPD we have a protocol. Whenever patient comes to us, every visit, it is compulsory that he gets an inhaler with him. Okay. Why? Because we are not giving any oral medication, no tablet formulation. We are giving only inhalers. Supposingly, imagine he's not taking it properly.
Incorrect way or
improperly. So what will happen is, the drug which are supposed to go to the lung is not getting delivered. So whenever the moment patient says, I'm already on inhaler, still
no improvement, or
first thing you should look for is compliance and the technique. The way whether patient is taking as the dose we have advised, and patient is taking it correctly. Technique is very, very essential, because that is the only way you are delivering the drug. And most commonly what I see is, we have seen multiple ways patients are taking. They use it as a perfume. They don't know how to use it. So they just spray it somewhere, and they sometimes use it upside down. And we get capsules also. So they break the capsule and have it. Sometimes they have the capsule, they swallow it instead of using it in inhaler. So I think every consultant should make a point that you should see how compliant is the patient and how is the technique.
No matter how
busy
you
or
make sure how long the patient has been taking it.
Yes, it has to be made compulsory for the patient.
Okay, so when we talk about warning signs, or as you said, there's worsening. So what could be a few worsening signs that every family member of a COPD patient must know?
See, if you see that your cough is increasing, your sputum production is increasing, your cough, whatever you're coughing out, the color is changing, and if you hear wheezing episodes, patients themselves say, I hear some musical sound, which is usually not there, but sometimes I have it. Or if you see the breathlessness, which was their baseline, they would have some breathlessness, and you suddenly see there's an increase in breathlessness. So always you should make sure you visit a experts.
Okay.
Not just go for a off the counter medication,
but
and
visit
just
an expert. Okay. So what are the few things you want every patient who is diagnosed recently with COPD to know and follow?
First thing is, accept that you have some problem.
Achha.
Okay. So most of the time what happens with the respiratory diseases, as you know, these are chronic conditions. The first thing is denial. The patient is not ready to accept what is happening with them. So they attribute it to multiple factors and they don't accept it. Next thing is, once you know that you have a disease, what they feel is, it is not, they feel once they start treating themselves with the inhaler, it will be cured. No, COPD is not curable. It's you can slow down the progression, but then it is a irreversible change that has already happened in the body. Next is, once you have started yourself on a treatment, taking it regularly, regular follow, and next is starting with the breathing exercise. What we call it as pursed breathing. So what is happening in patient with COPD is, they're finding it difficult to exhale. So empty out the lung because the airways are narrow. So now what we tell them is, you take a deep breath, make a pursed lip, and exhale it slowly, so
Acha.
that you prolong your exhalation and your
Acha.
lung is emptied out.
Mhm.
Next is most important, what we advise them is regular exercises. At least you should walk 20 to 30 minutes per day, at
Yeah.
least 5 times a week. Next, most important and most ignored part is
Mhm.
vaccination.
Ha.
So we give flu vaccination, we
Actually, I was
give,
coming to that. That what's
yeah,
the role of flu and
yes.
pneumonia
So
vaccination?
basically, these prevent you from serious illnesses
Mhm.
because these patients are prone for repeated infection.
Acha.
So basically, it reduces mortality also, and
Mhm.
it also reduces the morbidity and
Acha.
frequent flare-ups or infection what you have,
Mhm.
generally
Mhm.
pneumonias
Mhm.
and
Mhm.
everything.
Mhm.
So severity of
Mhm.
these illnesses are,
Mhm.
reduced because of the vaccination.
Mhm.
I'll tell you what is the basic problem we encounter in OPDs. Like for a child, you have a vaccination. So for adults also you have a vaccine. When you try to explain them,
Mhm.
they just know now recently that there is a COVID vaccination.
Mhm.
So other than that, when you tell them flu or pneumonia
Ah.
vaccination, आम्हाला कशाला
Mhm.
लसीकरण आम्हाला कशाला पाहिजे? They
Mhm.
have already grown up. This is
Uh-huh.
what the question comes
Because
from the
for them it is like vaccination is for kids.
kids. So that awareness is not there. So
Uh,
we should always make sure any patient with a chronic respiratory illnesses, irrespective of the age, we should consider for immunization, yeah,
vaccinations.
vaccination and immunization.
So, what's one common mistake you see in patients who are handling COPD long term? I mean, not newly diagnosed, but long term management, but still doing these
See,
mistakes.
once you start on inhalers, your disease stabilizes. Okay. The problem with them is what they feel is once the disease is controlled, they feel much better.
Uh-huh.
So they stop inhaler by
So, they
themselves.
believe that it's reversed
It's reversed, and they stop inhalers by themselves.
without consulting a
Yeah,
doctor.
consulting, and then all of a sudden they come with the flare-ups, and then again you are back to square one.
So, what message do you have for all our listeners about these flare ups? How bad are they when you abruptly stop a medicine like this?
See, it can be like just a normal infection too. It can even lead to a death.
Oh my
So
God.
the flare-ups can be that bad.
Mm-hmm.
So you may need just a OPD basis treatment for a flare-up.
Mm-hmm.
Sometimes you may even need a ventilator to control that flare-up. So it depends on the individual disease, and it
Mm-hmm.
depends on how severe is the flare-up.
Acha.
So it is always good to, before stopping any drugs, it is
Mm-hmm.
always good to consult your respective physician, then take a call. Don't stop inhalers abruptly.
Don't stop inhalers abruptly.
Yes.
That's the, I think, loudest message we can give right
Yes.
now.
Yes.
Okay, ma'am. So moving on to the next segment, which is a rapid fire round and some mythbusters round. So it's basically most of these questions we have already, asked you, but still some final closure on these questions. Okay. So the first one is inhalers are habit forming, myth or fact?
It's a myth actually. Inhalers are given with a curative intent. They're not habit forming. So these are the treatments for a disease. You have to take them.
Okay. Breathlessness always means asthma and nothing else.
No. So breathlessness can be, it can be a disease of other system also. So it can be asthma, it can be COPD, it can be related to heart disease, it can
Mm-hmm.
be even with the low hemoglobin. These all
Acha.
can lead to breathlessness.
Mm-hmm.
So the just what I want to say is, if you have breathlessness, kindly get it evaluated.
Noted. One early sign of COPD that most people overlook.
Usually early morning cough
Acha.
with a sputum production.
Okay. The most common wrong thing patients do with their inhalers.
Most common thing is not using it properly,
Uh-huh.
and second most common thing they do is stop it themselves. So
One symptom that should never be ignored even for a day.
any change in symptoms, whatever the baseline symptoms you had, if you find a slightest of the variation in those symptoms, you should never ignore it.
Okay. The simplest way to explain a COPD flare up in one line.
Worsening of the baseline status.
Okay. A home mistake families make during breathlessness episode.
I think the life threatening and the worst thing what they do is off the counter medication. They treat
Okay.
breathlessness by themselves.
Oh my God.
Yes.
Okay. One test you wish every high risk patient should do once a year.
Spirometry.
Spirometry. Most underrated part of COPD treatment.
Vaccination and physical activity.
Okay. One question patients must ask their doctor at every follow up.
Am I using my inhaler properly?
But what do they ask you most commonly?
So actually, what they ask is, when will my inhalers be stopped? This is the most common question which patient ask me. And then the next question what they ask is, will I be dependent on this all my life? Are
Okay.
this habit forming?
That's where I
Will I
think this
Yes.
inhalers are habit forming.
Yeah, because they have this myth, and I don't know why they carry this notion. See,
Yeah.
for a diabetes, you take a medication, you never ask whether these medications are habit forming.
Correct.
The same applies for a lung.
For a lung
You have
also.
some disease, you have to take inhaler. So there's nothing called as whether it is habit forming or not. It is a medication which you have to take. Rather, you should be very grateful that it is a inhaler which is
Inhaler.
directly going to the lung.
Yeah.
And whatever the inhalers we are giving, that is in a microgram,
Mhm.
compared to the rest of the medications which are in a milligram and gram doses. So
Mhm.
it is in microgram, so very less dose which you are inhaling.
Okay. So, on that note, before we end this podcast, uh, we have a ritual at Sahyadri Health Talks where we ask our guests to share some case with us, which has been challenging or, very heart touching, which has left a memory for you. So, do we?
See, actually, there are many such cases
Yes, I'm
which we
sure.
often come across. But what is the thing? Suppose a young patient comes to us.
Uh-huh.
Actually, recently in the last 1 week, we would have got some nearly 7 to 8 COPDs. Okay,
Oh
and
my
those
God.
who are less than 40 years of age.
Uh-huh.
Do you know what they say? We had one patient who said that I smoked only probably for a month or two,
Acha.
and I started developing symptoms.
Uh-huh.
I quit the smoking,
Hmm.
and I thought I'll be better.
Mm-hmm.
Then he has a small child at home, and he has to look after also. And he said the child is very small now, so I have to run around for my work also and look after the child also.
Mm-hmm.
And my breathlessness is so bad that I'm not able to manage both the side. So his question was, many people smoke for all these years,
Yeah.
nothing
मेरे
happens to
साथ
them.
ही क्यों?
क्यों मेरे साथ ही कि मैंने 1-2 महीने के लिए स्मोक किया and all
हाँ.
of a sudden I have these symptoms. See, you cannot define how much badly you will be affected because of the smoking. Some people are affected very badly, and some
Hmm.
people not. So what, to such patient, convincing such patient, when we got his PFT done, his lung function was severely hampered. I feel one was his occupational exposure, whatever, it was site visit, the pollution and everything.
Mm-hmm.
Next is his smoking, which triggered it. And
Mm-hmm.
next is he gave a history, though he gave a history that in childhood, he
Mm-hmm.
had these recurrent infections. In
Acha.
between, he was totally off these symptoms.
Mm-hmm.
So all these three factors
So it
attributed
all
to,
added up.
yes, added up, and it led to the severity of, though he was not that symptomatic presently,
Uh-huh.
his day-to-day activity is definitely
Were
hampered.
impacted.
Yeah, but he was not symptomatic for a long time.
Mm-hmm.
Recently he started developing these symptoms.
Mm-hmm.
But then the moment we got his X-ray and PFT done, we realized is his lung function is pretty bad. It's like 60%, 60 years old patient who has smoked for all these years. Whatever the lung function we commonly see,
Mm-hmm. Mm-hmm.
it was in the patient who was just 35 years old.
So it
I
was that
think,
bad.
yeah, I mean, it is very difficult to convince this patient that why to me.
Why to
These questions, it is very difficult to answer this question. Why to you? It is very difficult to.
True, true.
But they feel real bad. Ki why
Yeah.
did I even smoke for
But
three
it's
months?
just not that. That's what I mean. It's just not one factor. There are multiple
Yes,
factors
factors that
which
led
might
to.
have happened even long back. Like in this
Yes,
case, right? He had childhood recurrent infections.
infections,
Then it went all smooth. Then
occupational
continuous
exposure. Yeah,
exposures. So that all added up there.
but most of the time people only know about smoking.
Haha.
Smoking leads to asthma. This is what they know about.
Yeah,
So they don't consider all these factors,
yeah.
that these can also be cause for your COPD.
Uh-huh. Okay. So, ma'am, what would be a final message you want to give out to all our listeners who might be having, a COPD or has a family member who is suffering from COPD?
See, even before we say that a patient having COPD, I would just give a brief idea that if at all you have any symptoms, any cough with a sputum production that is present for more than 2 weeks,
Hmm.
and if you have breathlessness, if you have noticed breathlessness anytime, if you have wheezing episodes, repeated infection, I would suggest you always and always visit a pulmonologist and get an expert opinion before you start treating yourself. by off the counter medication. Next is, supposingly you have COPD, make sure you visit a pulmonologist. Make sure every often you meet them, have a regular follow up. Stick on to see what happens is, whenever they feel breathless now, they think that if I move more, if I walk more, I may feel more breathless. So usually they confine themselves to
Restrict their movements,
restrict their
basically.
movement. So in such patient, I would recommend that no, you should continue your breathing, you should continue your deep breathing exercises. You also have to continue your normal walking. So these all activity needs to be continued. Next is, the most important thing is, get yourself vaccinated.
Acha.
And if at all in your circle, anytime you find that they have a similar complaints as you have, if you sometimes you find that
Yeah.
in your relatives,
Yes.
you find that initially you had the symptoms, then you were
Yes.
diagnosed with COPD, and if you find somebody surrounding
With
you
similar kind of
similar
symptoms.
complaints, I think you should guide them to go to a proper pulmonologist and get themselves evaluated further.
Sure, ma'am. Thank you so much for helping us with so much of knowledge, and it was a wonderful discussion on COPD. And once again, thank you for giving us this time today. It was lovely having you on Sahyadri Health Talks. Looking forward to have you again on some other topic, which we can have an elaborate discussion once again. On that note, this is Dr. Tushita signing off Sahyadri Health Talks.